Hello everyone, let's go through an important update on the management of late intrauterine fetal death. This is frequently asked topic in exams and recent changes in misoprostol dosing should be noted carefully. I will highlight what has changed from the older guidelines, so focus on these differences. First, let's start with some key definitions to set the foundation. So here is the definitions. Before diving into the management updates, let's quickly clarify some key terms. Stillbirth. Stillbirth is defined as a baby delivered with no signs of life known to have died after 24+0 completed weeks of pregnancy. And what is late intrauterine fetal death? Late intrauterine fetal death refers to babies with no signs of life in utero after 24+0 completed weeks of pregnancy. You have to know that definitions, and also you have to know the incidence rate of late intrauterine fetal death. This is very important for the exam. The incidence rate is 1 in 250 babies. Remember that terms. Now let's move on to what has changed in management. Here is the key updates in the induction protocol. The first line intervention remains the same, but the misoprostol dosing has been adjusted at different gestational ages. The first line intervention is mifepristone 200 mg single dose followed by misoprostol. This remains the standard approach. There is no change here, but remember, in exams, if asked for the first step in the IUFD management, always answer mifepristone before misoprostol unless contraindicated. Here is the old GTG. Previously, the guidelines recommended 100 microgram every 6 hours before 26 weeks and 25 to 50 microgram every 4 hours at 27+6 weeks or more. Here is the new GTG. You have to remember that new one and forget the old one. The new one mentioning the misoprostol doses according to the gestational age 24+0 to 24+6 weeks of gestation. The misoprostol dose is 400 micrograms. The route is buccal, sublingual, vaginal or oral of misoprostol every 3 hours. 25+0 to 27+6 weeks of gestation, the misoprostol dose is 200 micrograms. The route is buccal, sublingual, vaginal or oral of misoprostol every 4 hours. And from 28+0 weeks of gestation, the dose is 25 to 50 micrograms vaginal every 4 hours or 50 to 100 micrograms oral every 2 hours. Why these changes matter? These refinements are based on the recent clinical evidence aiming to improve safety and efficacy, and the higher doses increase the effectiveness while remaining safe, and the more flexibility with routes of administrations allows for individual care. I have made an exam question example so that you can easily understand that. Here is the question. A 26+2 week pregnant woman presents with IUFD. Mifepristone has been given. What is the most appropriate misoprostol regimen? So according to new GTG, the answer is 200 microgram every 4 hours and the old one was 100 microgram every 6 hours. So you have to know the new one and forget the old one because it's a high yield topic and the small changes could make a big difference in your exam. So for your exam, focus on mifepristone first and misoprostol by gestation and overall patient-centered care. These changes are important for the real-world practice and also for your exam. Thank you everyone.